Hi, everyone. My name is Trudy McKanna, and I'm the Director of Medical Education for the Organ Health Division at Natera. I'm really excited today to be talking to you about genetic testing for kidney disease and specifically using the Renasight Kidney Gene Panel. My background is in clinical genetic counseling. I was a genetic counselor for 15 years before joining Natera. And so I know the process that a lot of patients go through from a clinical diagnosis to the importance of getting a genetic diagnosis and how Renasight can help fit into that nephrology landscape now. So I'd like to start and just talk a little bit about an introduction to the general concept of renal genetics, which you are, I'm sure, already familiar with, and hopefully after the symposium are even more familiar with. And then just talk a little bit on how Natera and Renasight really look at the utility of genetic testing for kidney conditions. So a little background on Natera. We started as a women's health company back in 2009 with a genetic test called Spectrum for pre-implantation genetic diagnosis. For a number of years, we were solely focused in the women's health market, but really became world experts, global leaders in cell-free DNA, which I liken to the ability to get a large amount of data from a very small source. So from our non-invasive prenatal test Panorama, which is our flagship test in the women's health market, we applied that cell-free DNA technology to two new business units, oncology and organ health, in 2019. In the organ health division, specifically our test for cell-free DNA is called Prospera, Transplant Assessment. And this looks at the risk for rejection based on elevated cell-free DNA in a recipient who's received a kidney transplant. The reason I'm bringing up a little bit of this history is because it's relevant to how we even ended up with the Renasight genetic testing panel. As we were talking to nephrologists and transplant nephrologists and introducing them to Natera and Prospera and cell-free DNA in our history, we had a lot of questions come up repeatedly. Oh, so, Natera is a genetic testing company. You do genetics. Do you have a test for renal genetics conditions? And the more we had this question, the more we started thinking that this was an unmet need that was being shared with us by providers. And given this feedback, we immediately launched into investigation on, is this something that we really may be well positioned to provide to the same providers we were talking to Prospera about, which sent us on our journey of looking at the literature and market research and what was already available in the field to help us develop this Renasight test. One of the first things that we did when we were looking to develop the Renasight panel is talk to nephrologists about how they were using or not using genetic testing in their practice. And one of the first nephrologists we talked to said to me, it's really interesting you're asking this question now. I just recently had a case where it changed completely my outlook on incorporating genetic testing into my practice. And she told us the story of her 30-year-old female patient with persistent proteinuria of unknown etiology. She did have a family history of kidney disease of unknown origin. And she had two children, an older son and a younger 2-year-old who had just recently developed hematuria and was referred to the pediatric nephrologist at this general nephrologist institution. The pediatric nephrologist didn't want to do a kidney biopsy on a child so young, so he proceeded to do renal genetic testing instead. These test results revealed a diagnosis of Alport syndrome, and subsequently, the provider I was talking to tested his mother and unsurprisingly confirmed that she also had Alport syndrome. And this provider was explaining to me, the value of having this diagnosis now in her patient was that Alport syndrome is a multi-system disease. So having that diagnosis then gave her the information that she needed to make referrals to check for sensory neural hearing loss, which can have an 80 to 90% incidence by adulthood. And also there are risks for vision abnormalities. So she could immediately refer for additional extrarenal specialists. She also knew the inheritance pattern, who else was at risk in the family. They could also evaluate for if it got to the point where kidney transplant was needed, who was appropriate or inappropriate for a living donor transplant assessment. And what was really interesting was this patient also was interested in having another baby, but she didn't want to have a baby with Alport syndrome. And because now that we knew that the genetic cause for the kidney disease in her family and the specific molecular diagnosis, she could actually have procedure called pre-implantation genetic diagnosis, where an embryo was tested for Alport syndrome prior to implantation, so to avoid having a child with Alport syndrome in her third pregnancy, which was then successful and disease-free. So hearing more of these stories, really brought us to the point where we knew that, some of the other things that were most important in ordering genetic testing, some of the other resources available, Natera was really well positioned to provide to the nephrology community. So after all of this research and feedback from the nephrology community, we developed the Renal Genetic Testing Panel, which is a diagnostic workup genetic panel for any patient with kidney disease, chronic kidney disease, nephrolithiasis, electrolyte disorders. And this includes cystic disease, tubular, glomerular, complement-related, and congenital or structural abnormalities. All of these are monogenic or single gene disorders that can result in kidney disease, where kidney disease is either the primary manifestation, for example, autosomal dominant polycystic kidney disease, or it could be part of many manifestations of a multisystem disease. There is one predisposition risk allele that I think everyone is familiar with, the APOL1 predisposition risk allele is also reported on the Renal panel. This reports standard reporting of pathogenic and likely pathogenic variants that would cause kidney disease. And we quote a detection rate of greater than 99% for finding significant variants across all of the genes analyzed. This is the lens that we look at as far as why would a provider have genetic testing? Why would a patient want to have genetic testing? There's diagnostic utility, so to confirm or reclassify a clinical diagnosis. Some of the papers that have been published on the incidence of reclassification of a clinical diagnosis following a genetic diagnosis were as high as 25%. And then also to establish a clinical diagnosis in the first place. This is kind of where a lot of people say, let's start ordering genetic testing if the etiology is unknown. That seems like a reasonable place to start because there's nothing to lose. But then also, once you have a diagnosis, what is the clinical utility? How do we apply that genetic diagnosis to management? There may be targeted therapies or workups that are now available specific to that diagnosis, and in some rare cases, even maybe specific to the specific genetic change that is going on in that individual. Anytime there's a genetic diagnosis, it always is part and parcel with family counseling and planning. Now that we know that there is a gene involved in genetic disease in a single person in a family, who else in the family could be at risk for a genetic condition? Are there early diagnosis benefits? Are there, as we discussed in that earlier example, are there reproductive risks that we should discuss or that families would want to know about? Are there extra renal referrals, such as the Alport syndrome case? And also where I think a lot of the benefit is going to come with genetic testing is in clinical trials and getting a confirmed clear diagnosis and a genetic diagnosis to advance science for more treatment and management options. We get a lot of questions saying, yes, this is great. I agree that there's a lot of clinical utility in incorporating genetic testing into my practice. I'm just not sure where to begin. I think this is kind of a helpful chart to break down some of the categories where a provider can start thinking about who they would want to start testing in their practice first. So on the left-hand side, there are risk factors for what could, make a genetic etiology more likely in a patient. So obviously, clinical diagnosis of a genetic condition. We want to get that molecular diagnosis to make sure, A, the clinical diagnosis is correct, and B, does the genetic diagnosis give us any additional information? Secondly, extrarenal manifestations. So is there something pointing to a more syndromic condition going on in this family outside of just kidney disease? A positive family history. 25% of patients with chronic kidney disease have a family history. Then those should be patients that should be tested for a genetic cause. Consanguinity or interrelatedness, early onset disease, rapid progression, or any kind of atypical presentation. We've seen in some of our studies, and just some of our results that have come back, that some of these can actually have two genetic conditions going on at the same time, which could account for why we're seeing this kind of atypical presentation. Other providers look at this on a more kidney disease type. What kind of cohort might I want to start testing to start? Again, I think unknown etiology is where a lot of providers start their testing. You could also look at cystic glomerular disease, tubular, nephrolithiasis, electrolyte disorders, complement-related disorders, patients with just a diagnosis of hypertension, just diabetes, or just structural abnormalities, or some combination of manifestations on this list. all can kind of help guide maybe a patient population that you'd want to start genetic testing with to see if then you broaden that out to more patients. This is a kind of small copy of what a Renasight result would look like, but the top box would indicate whether a positive result was found, so a positive genetic diagnosis, or if it was negative for a genetic diagnosis. Again, this reports pathogenic or likely pathogenic variants. There are variants of uncertain significance that are reported if requested, and these are changes that are found in the genes that have not been in the literature confirmed to be disease-causing, but may have some implications. The recommendation is not to make any clinical diagnosis based on this information, but some providers do find it valuable. We also would find if a patient was a carrier for a genetic condition, as you can see on this report. This means that they may carry a gene that could be passed on, that could cause disease if two copies, one from each parent, were passed down to a single child. But in most cases, carrier variants do not have any impact on the patient who themselves is the carrier. The report is typically about 2 pages, but it depends on what's found in the report. So just a quick review of, this is an initial Renasight experience where we looked at the first 1,000 results that came in just to see what we were seeing. Is this representative of a typical patient population? Can we glean any kind of information? So just very briefly, the overall age range was about 47 years of age. Only we had not started offering this routinely in pediatric patients. So there may have been, there was very few patients who were under 18, pretty even sex distribution. And overall, the majority of patients were reported to be Caucasian, although I will note that over a quarter of the patients did not have an ethnicity reported on the requisition. Out of the first 1,007 results, we had a 21% positive rate in genes associated with monogenic disorder. So if we included the APOL1 homozygosity, we actually had a 25% positive screen rate. 71.4% of the results were positive in more than 4 cases. So I'll show you on the next slide what the breakdown of the most common diagnoses were. But in about 13% of cases, there was only 1 positive. So this is kind of telling us why we're doing a broad panel, and that some of these rarer conditions may not be detected unless you're looking at a very large panel of genes. We had positive results in a total of 49 different genes, PKD1 being the most common at about just over a third of all positive results were diagnosed with PKD1. PKD2 accounted for another 10% of the results, and the 3 collagen 4A genes that account for Alport syndrome rounded out the top 5. 43% of genes, or 43 genes, account for 30% of all cases. So most cases were actually in this, what we call a long tail of rare conditions. And that's one of the reasons, again, why we have this broader panel, so that we can make sure that we catch as many patients who have these rare genetic conditions. We also looked at the first 1,000 cases that came in that were under 18. And this was the breakdown of the age range that we saw them in. So most of them were in the 13 to 18 year range. The yield was higher in this patient population at about 1 in 3. This is including APOL1. And the number of positive genes was actually much larger too than the adult population, 69 positive genes. And we had 24 cases where there was a dual diagnosis. The top 12 positive genes are shown on the right here. And I think what's interesting is, but not terribly surprising, is that there are 2 conditions where there was only 1 case in all of our adult population that were positive, HNF1 beta and a PAX2 gene. And 3 of the top 12 PEDS diagnoses had actually no diagnoses in our first 1,000 adult patients. So again, unsurprisingly, but I think this will be very interesting to look at in more depth, we do see a very different distribution of positive results depending on the age of onset. So one of the things that Natera knew we had to have in place to make this a test that was convenient, accessible, and comprehensive was we had to have a lot of other resources other than just a test. We have a very strong clinical support for the Renasight test. We have in-house genetic counselors who are specialized in renal genetics. We have field providers who also work with ordering clinics and can provide what we call a clinical outcome review and analysis, or a CORA, where we summarize centers' results and provide them with demographic data, results data, and can go through this with a provider and their colleagues, their ordering staff, to have a comprehensive look at what is the genetic disease results look like in your practice. What kind of conclusions can you draw from this? What kind of interesting cases or new learnings have you and have Natera, have we learned together from undergoing genetic testing? There's also easy ordering for Renasight. So this can be done with blood or saliva collection at home or in an office. There is absolutely no difference in the accuracy of a blood collection tube or a saliva or buccal swab collection tube. There are complementary pre and post-test genetic information sessions. So those same genetic counselors who specialize in renal genetics are available to both providers and patients even before they have the test. So if a provider is interested in, is this a reasonable patient to do genetic testing on, or a patient wants to just ask a few questions before they have genetic testing, that's available at no charge. And then after the result comes back and the provider is informed of the result, that those patients can also call and have complementary genetic information sessions to review those results. And the provider will get a report back from our on-site genetic counselors of what was discussed. We also know that some families have needs that go beyond the services that are provided with the genetic information sessions at Natera. And so we can also help provide resources where patients can get more comprehensive genetic counseling services. Results are available in about 3 to 4 weeks in general. And we have patient and provider-centric billing practices with low out-of-pocket costs to patients and pre-test cost estimates that is done by the Natera billing team. Okay, so in summary, there is proven clinical utility in genetic testing for broad panel kidney disease. There are a number of ways that this has clinical utility, including diagnosing, confirming, or reclassifying a condition, targeting therapy, providing family risk assessment, obtaining extra-renal referrals, and enrollment in clinical trials. Advances in technology in the past 5 or 10 years have created new opportunities for genes to be analyzed at a lower cost, savings that can be passed on to patients and providers. Comprehensive panels have benefits over targeted panels, as you can see with the long tail of disease genes that we were finding in our initial 1,000 cases that I showed you earlier, to find those rarer cases and to not miss something that maybe wasn't on the initial differential. And from beginning to end, there's provider and patient support with every test to make this journey as comfortable and as comprehensive as possible. And with that, I thank you for your time and attention, and I will close this presentation. Thank you.